Hi guys, we're going to focus on medication for concepts of care 2. And so when we focus on medications, we have to start with safety first. So we're really going to focus today in this lesson on medication administration and then that safety component that comes with it. So let's get started here. When we think about medication administration, we need to know our role and what everyone else's role is in that process. Prescribers' role, so these are our physicians, our physician assistants, our nurse practitioners. They all have that prescribing ability. So their role is to obtain the history, to diagnose the patient, to prescribe the medication, to monitor how that medication is working, and then to modify any therapy if needed. The pharmacist role, so the prescriber puts the med in the computer and the pharmacist reviews that order. They compare it to other medications that are being taken to double check that there aren't any interactions, and then they prepare and distribute that medication. Distribution of medication could include bringing it to the floor, or maybe they're going to load it into a med dispensing station, but that is the pharmacist role. And then our role comes into play. After it's been ordered by the physician and the pharmacist has checked it, then we get the order. We as nurses have to understand the medication. We are the last point before it gets to the patient. And we'll talk about those 3 checks before we administer that medication to our patient. We can't really rely on the prescriber or the pharmacist because if something goes wrong, yes, the physician is liable because they wrote the order. Yes, the pharmacist is liable because they dispensed the medication. But guess what? We are also liable because we give that medication. So we are expected to know that our medications that we are administering. We need to understand how to prepare it, how to administer it, and then also how to evaluate it. We need to develop and maintain our knowledge of medications, and we also need to determine the accuracy of the medication and safeguard that medication in storing it appropriately to help prevent any medication errors. So what do we need to know to give medication? We need to understand the medication itself. There are over 11,000 medications. Do you think we're going to know everything about every single one of those? Absolutely no way. But the expectation is that we're going to look it up. You may work on a floor that gives aspirin to every patient every day, and you're going to know that medication and not need to look it up each time. But one day you may be asked to give a different medication and you have no idea what it is, and you're going to be expected to look it up. So we can see here, we need to know the medication category. What is the mechanism of action? What are those therapeutic effects that we're looking for? What are some of the side effects? We know some side effects actually can be good. Things that happen, we expect to happen, but we actually need to monitor for those toxic effects. This is when the blood level may become too high. It could cause permanent damage to the body. Ototoxicity with vancomycin is very common, and that's that permanent damage to our hearing. But if we don't look that up and we don't know those toxic effects, we would not know that information. We also need to know the interactions. Most patients are on several medications and they do interact with each other. So we need to be very conscientious of any of that. We need to look at precautions, contraindications. How is it going to interact with my patient? Pharmacokinetics should be review for you from your pharm class. There are 4 phases to pharmacokinetics. Absorption is that first one, and it's going to determine the effectiveness. Distribution is that transportation of medication. Metabolism, and then excretion or that elimination of medication. Within medications, we know that the drug has multiple names. So again, this is review from pharmacology. You really need to be familiar with both names of the drugs that you are working with. Oftentimes, one of the names is very common because you hear it very frequently. Lasix, right? We hear that one all the time, but we also need to know that furosemide is the other name for it. So making sure that we know both of those names. The chemical name is not one we usually know. It's usually that composition of the medication. It's the generic and the trade name that we really need to be familiar with. These are the other things that you have to know if we're going to give medication. When a medication is prescribed, this is what is given to us. The provider puts it in the computer, he can handwrite it, or maybe even give it to us over the phone. These are the things they need to provide for us. The patient's name, first name, last name, the date and the time that the order is written, the name of the drug that we're going to be giving, the dose of the drug, which route are we going to be administering it, how frequently will we be administering it, and that will include the quantity. And then they also need to sign that written prescription, or it'll sign off in the computer if it's in the computer. So here's a really good example of a common prescription. You can see the patient's name, the doctor's name, you can see the medication, how many times it's given, the quantity. So all of these are very, very common things for our prescriptions. This is what you might see in the hospital system. This is the MAR, or the Medication Administration Record. Different hospitals are going to look differently depending on the system that they use. So again, different supply systems as well, different types of orders. If you look on page 278 in your ATI book, you'll see those different types of orders. We've talked a little bit about some of those in lab during Concepts 1, but remember, orders that you can give are standing orders, or routine are most common. The doctor starts it and it just goes until someone tells us to stop it, right? We get an order for Lasix, 20 milligrams daily. We're going to take that for the rest of our life until someone tells us to stop. The single or one-time dosing is just what it is. Vaccinations are very common, right? We give the flu shot one time this year. Stat versus now. Stat is that urgency. We're going to stop everything we're doing. It's a priority. We're going to do it now. Now means I'll do it in the next, maybe hour to hour and a half time frame. You'll have to look at your hospital policy to see what it is, that time frame for your hospital policy. PRN, we are pretty familiar with, right? It's based on as needed. It's based on those patient symptoms. Maybe it's PRN for pain, for itching, for fever. If the patient says, I'm in pain, but Tylenol is written for fever, you can't give that. So make sure your PRNs always tell us the reason why we're giving it. Standing orders are those orders that generate with a diagnosis. So pneumonia may have a standing order for an antibiotic, or maybe magnesium is going to be ordered for an electrolyte imbalance if we give it, or we have to give it if it drops below 1.5. So those are our standing orders. Routes of administration, we're going to look at each of these in lab this week, but just make sure you know where each of these are going. So oral, we can talk about sublingual or buccal. Sublingual means it's under that tongue. Buccal means it's in that cheek. Topical, we can do that directly or inside of a body cavity. Directly meaning it's on the skin, inside of the body cavity. Maybe it's a vaginal medication. We're going to put that in that vaginal area. Inhalation is one that gets breathed in. Parenteral, it means I'm avoiding that GI system, right? ID is intradermal. It's that top layer of that skin. Sub-Q is below the skin into that adipose or subcutaneous tissue. IM is into that muscle. IV is meaning we're putting it into that vein. You can see some other ones there: epidural, intrathecal, which is just our into our spine, intraosseous are our IOs that's going into our bone, intraperitoneal, intrapleural, and intraarterial. And then intraocular is that last one, and that is going into our eyes. So this terminology goes, we're going to talk about adverse effects of medications, and this is just some of the terminology that we can look at. Side effects, these are unexpected problems that could occur secondarily to the medication. Allergic effects is that immune response, right? The body interprets that as something foreign. Antibodies rush against that medication. So it's an allergic effect. Toxic effects, we've talked a little bit about. That's too much medication that's creating a high level in the bloodstream and can cause damage, even potentially death. Paradoxical effect is unusual or peculiar response to a drug that may manifest over a over response and under response, or the opposite of what we're expecting to see. Drug interaction is just what it is. And then tolerance is when we build higher levels that the body no longer reacts to. A lot of times we're going to see tolerance with our opioids, right? We take an opioid for pain. It's not really helping our pain, so we take more opioids. Our body develops that tolerance. We always need to ask about allergies, and we need to put that information in the chart. Before we give a medication, we need to ask about allergies every single time, because inevitably you're going to say, hey, Mr. Jones, I've got this medication, and you've asked him multiple times every time you come in for his allergies, and he's like, oh, I forgot to tell you, I'm also allergic to maybe the medication you're about to give. So make sure you're asking about those allergies every single time you give a medication. So what are some common signs and symptoms of drug allergies? A rash. Be mindful. A rash should be a full body rash. Okay, if they get a small little rash on the top of their hand, that may not be the allergy. So if they say, oh, I get a rash, you probably need to ask more questions. Urticaria, those are those hives, right? Hives are usually a typical allergic response. Fever, diarrhea, nausea, vomiting, anaphylaxis would be a big one to make sure we understand what are some of the signs and symptoms. If you're allergic to this medication, what happens when you take it is basically the question we need to ask. So now we need to measure our medication. We're looking at those dosage calculations, those things that you guys love so much, so that we can prepare to give this med. Most people understand the household method better than the metric system. We still use the metric system in the hospital because it's just more accurate. But when we discharge a patient to home, we need to convert some of those measurements into terms that they understand as household measurements. Most people have a teaspoon at home, but they don't understand the mils measurement at home. So we need to tell them, instead of telling them we're going to give 5 mLs, right? You're going to give 1 teaspoon. They're going to understand that as a home household measurement system. Tablespoons, ounces, again, those are the same thing, right? We want to give 30 mils. They're not going to understand that. You need to give 1 ounce of this medication. They will understand that as a household measurement. Remember that there are some disadvantages with those household systems just because they're inaccurate. So trying to still stay accurate, but giving those household systems that they may understand. You should know these conversions. If you don't, please know them. Make sure you are memorizing them. You're always going to report in decimals and not fractures. And remember, if we are giving 5 mLs, we're going to write 5 mLs. We're not going to put the 0.0 after, because if someone looks at that quickly and they miss that decimal point, they may see it as 50. So make sure if it's a whole number, there's no trailing 0, because that could be a problem. But we always use a leading 0. So half of an ml would be written as 0.5. If we didn't use that 0, and we just saw the 0.5 and we missed the point, we could give 5, which is quite significantly different than our 0.5. So always use decimals, never use fractures, always use those leading zeros, but never those trailing zeros. Make sure we're following all the rules for safe medications. When we give medication, we always do the things in threes. We know our rights for medications. We're going to go over those here in just a second. And we're going to make sure we go through those rights 3 times before we administer our medication. We're going to go to the Pyxis, our medication station. We're going to do a medication check. That's all those rights. After I have my medication in my hand, I'm going to go to the computer and I'm going to do a medication check. And I'm going to go through all my rights. Then I'm going to go to the bedside and I'm going to verify all those rights again with the patient. This helps the patient know what they are taking. Medication errors are huge. 400,000 errors every year, with 100,000 of those being medication related. These are reportable events, so you have to tattle on yourself. If you have a med error, you need to fess up. We need to know why it happened and how to prevent it in the future. So you can see that pie chart there on this slide. 78% of the time an error happens because the nurses are in a hurry, right? We're just in a hurry. If we would just slow down, 78% of the time that error's not going to happen, right? That seems a little outlandish, but slow down when it comes to medication. 68% of the time is poor handwriting. So many different reasons why we may report our medication errors, but knowing we have to report those medication errors. Occasionally you may be able to report these errors anonymously, but most of the time you have to own up to that error. You just need to you just need to know that you have to report them. We don't want it to happen again to other patients. Safety is always our top priority, and protecting our patient is very important. So watch out for any adverse outcomes. If we give an error, we give too much medication, we need to watch for those adverse outcomes and then make sure we're documenting those. Most of the time, those errors are documented inside the patient chart with just the facts, outside the patient chart with the problems that led to that error. So you don't want to write in a patient's chart, oh, it was in such a big, huge hurry and I accidentally gave the wrong medication to the patient, right? Wah, wah, don't do that. The patient chart just needs to be the facts. Mr. Jones inadvertently got 50 milligrams instead of 5 milligrams of his yada yada, whatever the medication is. And then outside that patient chart is when you're going to say, I was distracted, I was in a hurry, I couldn't read the provider's written prescription, whatever that led to that error will go outside of that chart. So again, sorry, this slide is just another types of nursing documentation errors: sloppy or illegible handwriting, maybe they didn't date, time, and sign it, right? We got to have all those pieces to that prescription. Incomplete or missing documentation, you can see a lot of them are documentation problems, right? So making sure every single thing on your prescription is available to you. And if it's not, ask them. It's okay to stop and ask before you give a medication error. Look-alike and sound-alike medications can be problematic. We can list 5 abbreviations that are error-prone, and I'm going to let you do that on your own. And then what are some medications that often are confused? And then how do you prevent those errors? Gabapentin is an anticonvulsant. Gemfibrozil is a cholesterol med, but they look pretty similar when you look at them together. You can also see there hydroxyzine and hydralazine, right? They both say 50 milligrams, they both say RX only, they both say 100 count. Could that be confusing? It absolutely could. Hydroxyzine is an antihistamine, hydralazine is a blood pressure medication. Very different reasons why we would give those. So this is how we can maybe prevent it. We can use tall man letters. So you can see the uppercase, the lowercase, and then you can see the tall mans. So look at the very bottom, hydroxyzine, hydralazine, right? We tall manned the OXY and the ALA, and it makes them look different. It makes them stand out to you so that you don't make that med error. All right, the 6 rights. You will need to know these for your entire life as a nurse. Right medication. Do I have the right medication in my hand? Do I know its brand name and its trade name? Is it the right patient? I'm going to use my 2 patient identifiers, and I'm going to ask my patient, what's your name? What's your date of birth? And I'm going to compare it to the computer. I'm going to compare it to his bracelet, and I'm going to make sure I have the right patient. Do I have the right dose? And I have looked that up before I've come in the room. Is it going in the right route? Is it going PO? Is it going in the eye? Is it going in the ear? Where's it going? Is it going in the right route? Is this the right time to give it? Is it Q4? Is it Q6? Is it daily? Is it PRN? Is it the right time? And then is it the right documentation? And if we are putting it into the computer, you are documenting that you have gone through these rights. So here is the right medication. We're going to make sure we're pulling the correct medication. We're going to look up that medication. We're going to know the name of that medication. Is it the right medication for your patient and what they are being treated for? Is it going to affect any of their lab values? Are you giving it because of their lab values? What are their adverse reactions that you are going to anticipate? So we're going to look at all of those things when we're thinking about, is this the right medication for our patient? The right dose. Is the dose that the physician has ordered, is it right? This is where your calculations are going to come into play. You're going to check your math. You're going to compare it to the pharmacist's math. Is it a therapeutic dose for my patient to be effective? So making sure that it is the right dose. If you need to cut or crush that medication, you need to make sure you verify that that medication can be cut or can be crushed. Remember our meds with that enteric coating? It's going to taste awful if we chew it. So we might need to think of something different when we're talking about the right dose and the right medication, and is it supplied the correct way? The right route. Can this medication be given in the route that it was ordered? If we're giving it as an injection, we're going to verify that that preparation is for parenteral use only. Is it the right time? Is it the right time for our medication to be given? Is the medication PRN? Is it scheduled? Is it one time only? Most of the time, hospitals will have a 30-minute window on either side of the time. Priorities have to come in play, though, if you have several medications due at the same time. So if you have a med that's due at 9 o'clock, most facilities will say you can give it anywhere between 8:30 and 9:30. But make sure if you've got lots of meds to give at 9 o'clock, that you're not trying to get it all put together at 9 o'clock, knowing you're not going to get into your patient's room in the next half hour. PRN, again, right, is our as needed. So you might have to say, you might have a PRN med for morphine, Q2 for pain. So making sure that you are waiting that Q2 before you can actually give it, right? The 30 minutes wouldn't matter beforehand on that one. The right documentation, making sure we're appropriately recording it immediately after we give the medication. If you're not giving that medication, make sure you're telling the MAR or the physician or somebody why you didn't give it. So you'll pull up your MAR, you'll scan your patient, you'll scan your med, you'll give the medication, you'll make sure they swallow it, and then you're going to say, yep, I gave that medication. Medical record documentation. Again, this is just review here. What was the medication we gave? What was the dose we gave? What route did we give it and the time we gave it? We're going to initial it off or sign it off on that computer. Were there any intentional or inadvertent omitted drugs that we did not give? Or did we give too much of something, right? Did the patient refuse the meds? Were there any medication errors? Those should all be documented each time. So we do want to make sure we maintain our patient's rights, though. Every patient still has rights. They have the right to be informed about a medication. Please do not walk into your patient's room with a cup full of medications without informing them of what they are taking. You need to take all of your medications in the original packaging, show them, tell them what they are taking, and educate them why they are taking the medication. If the patient understands what they are taking, they will be more compliant about taking the medications at home. But you have to teach the patient about each of those medications. Patients have the right to refuse their medications. It's always true for those that are cognitively intact. They may say no, but we should ask why. Why are they saying no? Why don't they want to take it? Maybe they have some really weird effects that make them feel funny when they take it, and they just haven't been asked why they don't want to take it. We need to have a medication history. Ask them about all the medications they're taking at home. What are they taking in the hospital? Consolidate all of those medications. When they're admitted, we're going to write down all those meds and then verify those orders. We need to make sure there isn't any drug-to-drug interactions. Most of the time that's going to come from your physician or your pharmacist. We need to be properly advising about experimental nature of any medications. We need to receive our labeled medications safely. Patients, again, have the right to see that label. Verify they're getting the right medication. All meds are individually packaged, so they should be able to see that label. Don't give any unnecessary medication. If your patient tells you that they've been taking amoxicillin every day for the last 5 years, that's not necessary. Make sure you're talking to the provider and advocating for that patient. And then be informed if medications are part of a research study. Work through the nursing process with medication administration. We've talked and talked and talked, right, about the nursing process. It's no different with our medication administration. The nursing process can get us through every aspect of nursing. So we're going to assess. What do we need to assess for before we administer our medications, right? We need to assess for allergies. Do they have allergies to medications, foods, dyes, right? In my world, dyes could be a big thing. If they have a red allergy dye, an allergy to a red dye, and I'm giving Tylenol that is red, that could be a problem. So making sure that you're looking at all of those. What is their medications? Do they have prescriptions at home? Are they using over-the-counter drugs? Are they using any street drugs, right? That's what we need to know. What is their diet history? Do they have diabetes? Level of education. Do they know about their disease process, their medication therapy? What is their social support, financial support? What is their attitude about medication? Do they understand why they're taking those medications? We need to make sure we try to remove all of the obstacles that are in the way. If they're complaining of getting up all night to pee and they take Lasix, maybe we can encourage them to take it in the morning. Teach them about their meds and the importance, right? That's all of that assessment and that data. Planning is our next phase in our nursing process. So organize yourself. Don't be rushed. Remember, 78% of errors are due to being rushed. Go through your 6 rights and your 3 checks. Take the label into the room so you can educate your patient. And then accuracy is key. Avoid distractions. Inevitably, you're in the med room, you're getting all your medications together, and your care assistant or another nurse or somebody comes in and says and asks you a question, and you totally lose concentration on what you're doing. Avoid those distractions. It is okay to say, give me 1 second, finish what you're doing, and then I will answer your question, okay? Also, administer only what you draw up. If your coworker comes in and she's got all of the meds and a couple of drawn up medications, and all of a sudden she's got to go take care of somebody else in another room and hands you the tray of medications and says, here, can you go give these to room 12? It's okay for you to say no. Okay, you don't know anything about room 12. You didn't draw up any of these medications. You have no idea what's going on. It's okay to say no. 6 checks three times. Again, I'm going to say it over and over again, and then just using that clinical judgment. And then we're going to evaluate. We've given the medication. We're going to evaluate. Did it work, right? That's that reassessment piece, which I am going to hone in on you when we get to our peds world. So you give a medication, you intervene. There's no sense in you intervening if you're not going to evaluate if it worked. So making sure you evaluate, did the medication work for you? Were there any adverse reactions? Do they have any toxic reactions? What's going on that you need to evaluate? All right, that ends the safety part. Let's move into medication administration. I'm going to go through this pretty quickly because we are going to do a lot of this in lab this week. So medication administration, we've talked about oral, right, by mouth. Topical can be on the skin, in the nose, on the eyes, ears, vaginal, rectal, right? It could be inserted, it could be on the skin. Inhalation, irrigation, parenteral, and injection. Some of these. If we are administering our oral medications, these are our tablets, capsules, liquids, suspensions, elixirs, lozenges, right? Anything that can go in our mouth. Remember, oral medications are a slower onset, less potent than other routes. So there is a barrier for absorption. They have to pass through the layer of those epithelial cells that line that GI tract. So don't anticipate if you give an oral medication for fever or pain that it's going to work very quickly, okay? So make sure you know that evaluation time. It is the easiest, it's the most common, but again, it's going to just take, it's a slower onset. So just be aware. Administration of oral medications, oral route, having the patient swallow. Enteral route is going through an enteral tube. Remember our NG tubes, our G tubes that we talked about. Sublingual is under the tongue. Buccal is in that cheek area between the tongue and that cheek. So enteral, this should be review, are that small bore feedings. Remember, it's still considered oral because it's going into the GI tract. We need to probably use liquids as when possible, right? We can't shove a pill down their tube, so we have to put it in liquid form. If the medication is to be given on an empty stomach, make sure it's 30 minutes before or after that feeding. And then just watch for those drug-to-drug interactions. Those usually are very higher, right? Because it's going right into the stomach, going right into that lining. So this shows you just sublingual and buccal routes. We want to make sure we leave that medication in place until it completely absorbs. No eating or drinking while the medication's in there, or until it's completely dissolved. Crushing or cutting meds. Remember, we want to talk to our pharmacist before we do this. Some medications cannot be crushed or cut, so make sure you're talking to the pharmacist first. But those are a bunch of tools that you'll see. That one in that right bottom corner is pretty old school. Probably won't see that. You'll definitely see the cutting tool if you need to cut meds in half. Controlled substances. Remember, those are our scheduled 1 through 5s. That should be kind of maybe review from pharmacology. We want to make sure that if we are giving narcotics, that we are disposing any waste in front of someone else. You have to have a witness just to protect yourself. I'm going to be quite honest. I will bring somebody in as a witness just to say, hey, I have this 5 milligram tablet of whatever my med is. I'm actually giving all of it. I just want you to see I haven't done anything with it, and I'm going to go give it. If you're cutting it in half, you need to have somebody there to see that you've cut it in half and you have appropriately disposed of it, that you haven't pocketed it, that you're not saving it for someone at home, saving it for yourself later. You have to have a witness if you are wasting any narcotics. So make sure you do that in front of somebody. I cannot stress that enough. All right, topical medications. Let's talk about applied to the skin or body cavity. We're going to use standard precautions when we're using these, right? We're going to put on our gloves. We're going to use a tongue blade or a cotton swab or something to apply this medication. What we don't want is the medication on us, right? This is for our patients, not for us. We may have to use surgical asepsis if we're applying it to an open wound area. So again, skin, we've talked about using those gloves. If it's an open wound, we're going to use sterile technique. We're going to clean that skin first, right? We're going to get all of the yuck off of the skin so that that medication can really absorb well. Transdermal patches. This is a disc or a patch that contains medication. It's usually a systemic effect. Hormones, narcotics, cardiac meds, nicotine patches, right? You've heard about some of those. You're going to put the patch on. You're going to initial with a date and time. And then you're going to make sure you remove it when it needs to be removed. Some patches need to be removed every 24 hours, every 48 hours, every 7 days. So just make sure you know when it needs to be removed. Make sure you remove the old one before you put on a new one. Make sure you're wearing gloves, right? We don't want the medication on us again, and that we're just disposing that old patch into some type of drug wasting container. All right, nasal instillation. So we're putting drops into our nose. We're going to use standard precautions. We're going to use our gloves. Patient should lie supine with that head positioned to allow that medication to enter the appropriate nasal passage. They're going to breathe through their mouth. They're going to stay supine for about 5 minutes, and we're going to tell them, please don't blow your nose for about 5 minutes. For sprays, make sure you prime it first. Insert it into the nose, spray away from the center of the nose while the patient inhales. And you can just see the picture there of what we are trying to accomplish. If we're doing eye medication, these could be drops or ointments. We want to avoid that cornea. We're going to avoid the eyelid with the dropper or the tube, right? We don't want that to touch, because if they have an eye infection that we're using that for, and then we touch that the tip of that dropper to the eyelid, we just put the infection on our medication lid, right? And then we just need to dispose of it and start all over again. So make sure that we're giving some good space there. If we're doing the eye ointment, you can see that on the bottom. It's like a little ribbon is what you'll sometimes hear right there in the bottom of that eyelid. Again, trying to avoid not touching the medication. It looks like in that picture they are touching. You should not be touching. If you are giving eye medications and they have contact lenses, make sure they kind of take those out. If you're giving a disc intraocular, it can resemble a contact lens. So just make sure you're inserting it and removing it like a disc. Again, we're going to talk about adverse reactions. Okay, ears. Sterile solutions are usually used in the ears. Making sure you're using standard precaution like our picture with the gloves. Don't force any medications in. If they are greater than 3, you're going to pull that pinna of that ear up. If they are younger than 3, you're going to pull it down. Ooh, that's little. Ear medications, that's just going to walk you through how to administer those, washing your hands, rubbing the medication bottle between the palm of your hands. It's nothing worse than putting cold drops in your ears. That is very, very painful. So make sure you're warming that. I'm going to let you read that slide. This just shows, again, over 3, you're pulling that pinna up. Under 3, you're pulling it down. Vaginal instillation, you can use a gloved hand, or you can use some type of mechanism to get that medication in. Make sure you're providing perineal care if it's needed. They should lie supine for at least 5 minutes to just help with some absorption. Rectal suppositories, right? We're putting our patient on their left lateral side or in Sims position. A lot of times we're using we're doing this laxatives, fecal softeners, because they're having some type of infection or constipation. Make sure you're lubricating before you insert those, having them breathe deeply. Try to relax as much as possible. Remember, we're inserting that suppository into that rectal wall. Again, there's incorrect and correct placement there. You can see, you can just visualize that slide there. Inhalation medications, these are usually your meter-dosed inhalers, your MDIs. You might hear it. You may hear it also as nebulizer treatments. A lot of times these are for asthmatics. Could be for our little croup babies if we're talking about racemic epinephrine. These are all just inhaled medications that we're going to provide for our patients. So how do we do that? We're going to walk through these in lab, but right, we shake it really good. We make sure the canister has medication still left in it. We put it into a spacer. Everyone should have a spacer. It doesn't say that on the slide. Everyone should have a spacer. And then you push the meter dose inhaler. It goes into your spacer. You have the patient breathe 3 or 4 really good breaths. Hold it in for 5 to 10 seconds. Make sure you're rinsing the mouth out. That's if you're just putting the inhaler right into the mouth. Most of the time you're getting it really good into their lungs if you're using that spacer. So always educate your families. I don't care if you're 6 months old or 60 years old. You should be using a spacer if you have an MDI. Patient teaching is always going to be at the forefront when we're talking about medications. Make sure you're reviewing those techniques of medication administration with your patients. Remind them to take their medications as they are prescribed and for as long as they are prescribed. A lot of times you'll see amoxicillin prescribed or some type of antibiotic prescribed for a 10-day course. They feel better after 5 and they just stop taking it, right? They still need to take it. Instruct the patient not to alter any of the dosages. Don't share your medications. Make sure that if they're taking over-the-counter medications, you know about it, or if they're gonna start taking over-the-counter medications and they take a medication every day, make sure they inform their provider, like, hey, I wanna take this over-the-counter, is it okay? And then always make sure you document your teachings. And that concludes this lesson on medication safety and medication administration. If you have any questions, you can shoot me an email or we will chat about it in class. Thanks, guys.